Welcome to Pediatric Case Review. Today we present a comprehensive case-based lecture on pneumothorax in children. This session covers 15 carefully designed clinical cases exploring recognition, pathophysiology, diagnostic approach, and management strategies. We will walk through real-world scenarios involving primary spontaneous pneumothorax, tension pneumothorax, secondary causes, imaging interpretation, and surgical decision-making. Whether you are preparing for board exams or strengthening your clinical skills, this lecture is designed to sharpen your thinking. Let us begin. Case 1. A 15-year-old male with no significant past medical history presents with sudden onset of sharp, right-sided chest pain. The pain began while lifting a heavy backpack. He denies cough, fever, or trauma, and reports the pain worsens with deep breathing. On physical examination, tachypnea with respiratory rate 28 per minute, mild tachycardia, and oxygen saturation 94% on room air. The patient appears uncomfortable but alert. What is the most likely diagnosis? Option A, asthma exacerbation. Option B, pulmonary embolism. Option C, spontaneous pneumothorax. Option D, musculoskeletal strain. The correct answer is option C, spontaneous pneumothorax. This is a classic presentation of primary spontaneous pneumothorax in a tall, thin adolescent male. Key features include sudden onset sharp chest pain during physical activity, pleuritic pain worsening with breathing, tachypnea, and mild oxygen desaturation. There is no underlying lung disease history. The typical patient profile is a tall, thin adolescent male aged 15 to 19 years, and risk increases with height and low body mass index. Asthma would present with wheezing, pulmonary embolism is rare at this age without risk factors, and musculoskeletal strain does not cause oxygen desaturation. Case 2. A 3-year-old girl presents with 12 hours of increasing irritability, refusal to eat, and mild tachypnea. On examination, she is alert but appears uncomfortable. Breath sounds are diminished on the right side, and there is decreased chest wall movement on the right. A chest X-ray shows a small, subtle right-sided pneumothorax. What is the most appropriate next step? Option A, observe with supplemental oxygen. Option B, perform needle aspiration. Option C, insert a chest tube. Option D, administer systemic corticosteroids. The correct answer is option A, observe with supplemental oxygen. Small, stable pneumothoraces in young children can be safely managed conservatively. Supplemental oxygen accelerates air reabsorption by creating a nitrogen washout effect, increasing the pressure gradient that drives pleural air back into circulation. This approach avoids unnecessary invasive procedures, and close monitoring ensures early detection of any deterioration. An important clinical pearl: young children may present with subtle, nonspecific symptoms such as irritability and feeding difficulties rather than the classic chest pain seen in older patients. Always consider pneumothorax in a young child with unexplained respiratory symptoms. Case 3. A 17-year-old male with a history of one prior pneumothorax episode 6 months ago presents to the emergency department with sudden onset of sharp, left-sided chest pain. The pain began immediately after performing a Valsalva maneuver during weightlifting at the gym. He denies fever, cough, or recent trauma. On examination, he appears comfortable but reports moderate pain with deep inspiration. Vital signs are stable with normal oxygen saturation. Physical examination reveals decreased breath sounds on the left side. A portable chest X-ray confirms a left-sided pneumothorax. What is the most likely underlying cause of this recurrent pneumothorax? Option A, cystic fibrosis. Option B, apical bleb. Option C, Marfan syndrome. Option D, asthma. The correct answer is option B, apical bleb rupture. Recurrent pneumothorax in adolescents strongly suggests the presence of underlying subpleural apical blebs. Blebs are thin-walled air sacs that form at the apex of the lung, more commonly in tall, thin adolescent males. Computed tomography scans reveal blebs in up to 60% of primary spontaneous pneumothorax cases. Risk factors for recurrence include male gender, tall stature, visible apical blebs on computed tomography, and smoking history. This patient has now had 2 episodes, which is a strong indication for surgical evaluation. Marfan syndrome is possible, but no systemic features were mentioned. Asthma and cystic fibrosis have different clinical profiles. Case 4. A 14-year-old boy is brought to the emergency department following a bicycle accident. His clinical presentation includes severe respiratory distress with rapid, shallow breathing. Blood pressure is 85/50 millimeters of mercury, and heart rate is 140 beats per minute. Tracheal deviation is present to the right side, and breath sounds are absent on the left chest. Jugular venous distension is also noted. What is the most urgent initial intervention? Option A. Administer high-flow oxygen therapy. Option B. Insert chest tube immediately. Option C. Initiate mechanical ventilation. Option D. Perform needle decompression. The correct answer is option D. Immediate needle decompression. This patient has tension pneumothorax, a life-threatening emergency. The classic triad is hypotension, tracheal deviation away from the affected side, and absent breath sounds. Jugular venous distension indicates impaired venous return due to mediastinal compression. Needle decompression must be performed immediately at the second intercostal space, midclavicular line, using a 14 to 16 gauge angiocatheter. Do not delay for imaging confirmation. Chest tube insertion follows after initial decompression to provide definitive relief. Every second of delay in tension pneumothorax increases mortality risk significantly. Case 5. A 16-year-old male presents to the emergency department with sudden onset of left-sided chest pain that began during basketball practice. He appears uncomfortable but is hemodynamically stable. Examination findings include decreased breath sounds on the left side, hyperresonance to percussion over the left chest, normal breath sounds on the right side, no tracheal deviation noted, heart rate 95 beats per minute, and blood pressure 118 over 75 millimeters of mercury. What is the most likely mechanism explaining these physical examination findings? Option A. Lung collapse due to air in the pleural space. Option B. Pleural effusion with fluid accumulation. Option C. Pulmonary edema with alveolar flooding. Option D. Bronchospasm with airway constriction. The correct answer is option A. Lung collapse due to air in the pleural space. Air accumulating in the pleural space acts as a physical barrier. Because air is less dense than tissue, it creates hyperresonance on percussion, reflecting a hollow drum-like quality. At the same time, air blocks the transmission of breath sounds, explaining why breath sounds are diminished or absent on the affected side. This is the fundamental physics of pneumothorax. In contrast, pleural effusion causes dull percussion with decreased fremitus. Pneumonia causes dull percussion with crackles. Asthma produces wheeze and prolonged expiration. These patterns are essential for differential diagnosis at the bedside. Case 6. A 13-year-old boy is brought to the emergency department after a bicycle accident. He is in severe respiratory distress. Examination reveals tracheal deviation to the right, distended neck veins consistent with jugular venous distension, absent breath sounds on the left side, and tachycardia with mild hypotension. What is the most likely diagnosis based on these examination findings? Option A. Hemothorax. Option B. Pulmonary contusion. Option C. Tension pneumothorax. Option D. Cardiac tamponade. The correct answer is option C. Tension pneumothorax. Tracheal deviation away from the affected side combined with jugular venous distension are pathognomonic signs of tension pneumothorax. These findings indicate progressive mediastinal shift compressing the heart and great vessels, impairing venous return to the heart. The result is obstructive shock with rapidly deteriorating hemodynamics. Remember the emergency recognition formula: tracheal deviation plus jugular venous distension plus hemodynamic instability equals tension pneumothorax. Immediate decompression is required. Cardiac tamponade can mimic this, but shows muffled heart sounds, not absent breath sounds. Case 7. Pathophysiology case. A 16-year-old male with no known lung disease presents with sudden onset of sharp left-sided chest pain while at rest. Chest X-ray confirms a left-sided pneumothorax. He was previously healthy with no history of trauma. What is the most likely underlying pathophysiological mechanism? Option A. Traumatic chest wall injury. Option B. Spontaneous bleb rupture. Option C. Severe bronchospasm. Option D. Pulmonary embolism. The correct answer is option B. Spontaneous bleb rupture, specifically rupture of a subpleural apical bleb. Primary spontaneous pneumothorax occurs when these thin-walled air sacs at the lung apex rupture without any triggering trauma. The bleb rupture allows air to escape into the pleural space, destroying the normal negative pleural pressure that keeps the lung expanded. Up to 60% of primary spontaneous pneumothorax patients have visible blebs on high-resolution computed tomography. This condition is more common in tall, thin adolescent males due to greater mechanical stress at the lung apex from increased height gradient. Understanding this mechanism is key to anticipating recurrence risk and planning surgical management. Case 8. Pathophysiology case. A 14-year-old boy with asthma experiences a severe coughing episode and suddenly develops hypotension and tachycardia, absent breath sounds on the left side, and severe respiratory distress. What is the primary pathophysiological mechanism causing these findings? Option A, bronchoconstriction from severe asthma exacerbation. Option B, alveolar hemorrhage with hemoptysis. Option C, pulmonary edema from cardiac failure. Option D, mediastinal shift from tension pneumothorax. The correct answer is option D, mediastinal shift from tension pneumothorax. In this asthmatic patient, the intense Valsalva effect from severe coughing ruptured an alveolus, creating a one-way valve effect allowing air to enter the pleural space but not escape during expiration. Progressive pressure buildup compresses the heart and great vessels, causing mediastinal shift and impaired venous return. Cardiac output falls rapidly, producing obstructive shock. Asthma is a known risk factor for secondary spontaneous pneumothorax precisely because of this mechanism. The sequence is air enters pleural space, one-way valve effect, progressive pressure, mediastinal shift, venous return impairment, obstructive shock. Do not delay for imaging. Decompress immediately. Case 9. Investigations case. A 15-year-old male presents to the emergency department with acute onset of left-sided chest pain that began 2 hours ago while playing basketball. He denies any trauma, cough, or fever. Vital signs: heart rate 95 beats per minute, respiratory rate 22 per minute, oxygen saturation 96% on room air. Physical exam reveals mild tachypnea, but no obvious distress. A supine chest X-ray performed in the emergency department shows no abnormalities. The patient continues to complain of persistent chest pain. What is the most appropriate next step? Option A, repeat supine chest X-ray in 4 hours. Option B, perform bedside lung ultrasound. Option C, order a computed tomography scan of the chest. Option D, observe the patient for 24 hours with pain management. The correct answer is option B, perform bedside lung ultrasound. Bedside ultrasound is superior to supine chest X-ray for detecting small pneumothoraces. Ultrasound sensitivity reaches up to 94%, while supine X-ray sensitivity is only 50 to 60%. The negative predictive value of ultrasound is 93.4%. On ultrasound, a normal lung shows the dynamic seashore sign reflecting lung sliding. In pneumothorax, lung sliding is absent and the barcode sign appears, indicating air in the pleural space. The lung point sign, where sliding appears on one side and disappears on the other, is 100% specific for pneumothorax. Point-of-care ultrasound has truly revolutionized pneumothorax diagnosis in pediatric emergency medicine. Case 10. Investigations case. A 13-year-old girl with a history of asthma presents with right-sided chest pain. Bedside lung ultrasound is performed and reveals absence of lung sliding and a distinct lung point sign. What is the most likely diagnosis? Option A, pneumothorax. Option B, pleural effusion. Option C, consolidation. Option D, normal lung. The correct answer is option A, pneumothorax. The lung point sign is 100% specific for pneumothorax. It represents the exact interface between the normal lung and the pneumothorax region. When you visualize the lung point, you are seeing lung sliding present on one side of the probe and absent on the other, confirming air in the pleural space at that boundary. On M-mode ultrasound, normal lung produces the seashore sign with a grainy lower portion. Pneumothorax produces the barcode sign with horizontal lines throughout. Pleural effusion shows fluid between layers and does not produce absent sliding in the same pattern. The lung point sign is a definitive diagnostic finding when present. Case 11. Investigations case. A 16-year-old male presents to the emergency department with his first episode of spontaneous pneumothorax. He is a tall, thin athlete with no previous history of lung disease or chest trauma. Chest X-ray confirms a moderate right-sided pneumothorax. The patient is hemodynamically stable and responding well to initial conservative management with supplemental oxygen. In this clinical scenario, when is a computed tomography scan most appropriate? Option A, routine screening for all first episodes. Option B, confirming the diagnosis when X-ray is positive. Option C, pre-surgical evaluation for recurrent cases. Option D, only indicated in infants under 2 years. The correct answer is option C, pre-surgical evaluation for recurrent cases. Computed tomography scanning is not routinely indicated for a first-time primary spontaneous pneumothorax. The diagnosis is already confirmed on chest X-ray, and computed tomography adds radiation without changing initial management. However, computed tomography becomes essential when planning surgical intervention, specifically video-assisted thoracoscopic surgery with pleurodesis for recurrent cases. High-resolution computed tomography identifies apical blebs in up to 60% of recurrent cases, guiding surgical planning and risk assessment. The indications for video-assisted thoracoscopic surgery include recurrent pneumothorax, persistent air leak beyond 48 to 72 hours, and bilateral pneumothorax. Case 12. Treatment case. A 14-year-old male presents to the emergency department. A small pneumothorax is detected on chest X-ray following mild chest discomfort. The patient appears comfortable and is not in respiratory distress. Vital signs: stable, oxygen saturation 96% on room air, respiratory rate 18 per minute, blood pressure normal for age. What is the most appropriate initial management for this stable patient with a small, asymptomatic pneumothorax? Option A. Insert a chest tube immediately. Option B. Perform needle aspiration. Option C. Start prophylactic antibiotics. Option D. Observation with supplemental oxygen therapy. The correct answer is Option D. Observation with supplemental oxygen therapy. According to British Thoracic Society Pediatric guidelines, a small pneumothorax less than 2 centimeters at the hilum in a stable, minimally symptomatic patient is managed with observation and 100% oxygen. 100% oxygen creates a nitrogen washout effect, accelerating air reabsorption by up to 4 times the normal rate, increasing from 1.25% per day to 4 to 6% per day. For large pneumothorax greater than 2 centimeters with symptoms, needle aspiration or chest tube is used. Any size with hemodynamic instability requires immediate chest tube. Tension pneumothorax requires needle decompression immediately. Antibiotics have no role here. Case 13. Treatment case. A 17-year-old male with a history of spontaneous pneumothorax has a persistent air leak 72 hours after chest tube placement for recurrent pneumothorax. The patient remains stable, but chest X-ray shows incomplete lung re-expansion. There is no improvement despite proper chest tube positioning and suction. What is the most appropriate next step in management? Option A. Insert a second chest tube. Option B. Refer for video-assisted thoracoscopic surgery. Option C. Perform needle aspiration. Option D. Continue observation with chest tube in place. The correct answer is Option B. Refer for video-assisted thoracoscopic surgery. A persistent air leak beyond 48 to 72 hours with incomplete lung re-expansion is a strong surgical indication. Video-assisted thoracoscopic surgery with pleurodesis is the gold standard treatment in pediatric patients for this scenario. It allows direct visualization, definitive bleb resection, and creation of pleural adhesions to prevent recurrence. The success rate exceeds 95% with low morbidity in children. Pleurodesis works by inducing inflammation between the visceral and parietal pleura, creating permanent adhesion that prevents future air accumulation. Early surgical referral improves outcomes and reduces complications in these cases. Case 14. Complications case. A 16-year-old male athlete had his first spontaneous pneumothorax 8 months ago. He now presents with a second episode of left-sided chest pain. Physical examination reveals decreased breath sounds on the left side. Chest X-ray confirms left pneumothorax. What is the strongest risk factor for pneumothorax recurrence in this patient? Option A. Presence of apical blebs. Option B. Smoking history. Option C. Patient age. Option D. Physical activity level. The correct answer is Option A. Presence of apical blebs. Apical blebs are the primary source of recurrent pneumothorax in adolescents. Patients with visible blebs on imaging have 3 to 4 times higher recurrence risk compared to those without blebs. High-resolution computed tomography identifies blebs in up to 60% of primary spontaneous pneumothorax cases. The recurrence rate with apical blebs is approximately 65% compared to 23% without blebs. Male gender and tall, thin body habitus are additional risk factors. Early identification of apical blebs on computed tomography guides surgical planning and patient counseling about activity restrictions and recurrence risk. Case 15. Systemic associations. A 14-year-old female presents with recurrent episodes of pneumothorax. She has a notable history of joint hypermobility and no previous respiratory symptoms. Physical findings include hyperextensible skin on examination, joint hypermobility affecting multiple joints, and no cardiac murmurs detected. What is the most likely underlying systemic condition? Option A. Asthma. Option B. Cystic fibrosis. Option C. Marfan syndrome. Option D. Ehlers-Danlos syndrome. The correct answer is Option D. Ehlers-Danlos syndrome. Joint hypermobility combined with recurrent pneumothorax and hyperextensible skin strongly suggests a connective tissue disorder, specifically Ehlers-Danlos syndrome. This condition involves defective collagen synthesis leading to fragile connective tissues including the pleura, predisposing to recurrent pneumothorax. Red flags for connective tissue disease in pneumothorax patients include joint hypermobility, frequent dislocations, skin hyperextensibility, unusual scarring, tall lean body habitus, and family history of connective tissue disorders. Marfan syndrome typically presents with tall lean habitus, arachnodactyly, and cardiac abnormalities such as aortic root dilation. Early recognition guides genetic counseling and prevents future complications. We want to tell you about the Pediatric Case Review community on Patreon. Our community is designed to be your complete learning library. All videos are organized by system, so you can access every lecture in one place without searching through scattered content. All presentation slides used in our videos are also available as downloadable photos, so you can read, review, and practice all questions at your own pace whenever you want. For details on how to subscribe and join the community, simply comment below this post, and we will message you directly with everything you need. This concludes our comprehensive case-based review of pneumothorax in children. The key takeaways are early recognition through clinical presentation and physical examination, bedside ultrasound as a first-line diagnostic tool when X-ray is negative, conservative management with oxygen therapy for small stable cases, immediate needle decompression for tension pneumothorax without waiting for imaging, video-assisted thoracoscopic surgery with pleurodesis for recurrent episodes or persistent air leak, and always consider underlying systemic conditions and secondary spontaneous pneumothorax. If you found this lecture helpful, please follow the Pediatric Case Review channel for more evidence-based presentations like this one. If you have any clinical questions or topics you would like us to cover, please leave them in the comments below. We would love to hear from you.